Assalamu alaikum. The clinical day. We have Mrs. Lisa, 36 years, with complaint of vision problem. Okay, ready? Let's
Okay.
start. Here you
Okay.
go.
Hello, I am Dr. Mitwalli, the doctor in clinic today. May I confirm you are Mrs. Lisa, 36 years?
Yes, I am.
Okay, Mrs. Lisa, welcome. We are here today to discuss your health condition and I'll examine you. Is this okay with you?
Sure, doctor.
Okay, can you tell me more what bring you to the clinic today?
Yeah, doctor. Actually, I feel unwell with my vision since almost 1 year now. I feel this problem, and I'm coming and going back to my GP until he referred me to you now.
Mhm. I'm sorry for that. So this condition started 1 year ago.
Yes.
Okay, and it is in one eye or both eyes?
Doctor, you can say it's both eyes.
Mhm. Okay. And it is by time, as you said, it is worsening.
Yes.
Yes. And this is first time you have this condition.
No, doctor, it comes and goes. It's not the first time.
Mhm. Okay, it comes and goes in both eyes also.
Yes.
Mhm. So when was the first time coming this problem for you?
1 year back, I faced for first time in my life.
Mhm. Okay, so through this year it come and go.
Yeah. Yes,
Mhm.
exactly.
And you mean by problem in your vision, like it become blurry or you can't see at all? Can you describe it?
No,
Mm.
no, doctor, I can see well, but sometimes I feel the thing like
Sorry again, the thing is
double.
double. Yeah.
Yeah, I can
Okay.
see the same thing twice.
Yeah. Okay. Okay. I'm sorry for that. And if you see double, if you cover one eye, you notice that it's improving. If you
No,
try,
doctor, it's not.
no. Okay. And do you notice that it is come more at night, at end of the day?
No, doctor,
Okay. And
it's
it
not
is.
related.
Mhm. And the vision also become hazy or just double?
No, only double.
Mhm. And what about the color vision? Is affected?
So far, it's good, doctor.
Mhm. And there is any pain with this double vision you noticed in
Yeah,
your eyes?
yes, I feel at the back of my eyes some pain, yes.
Mhm. Okay. And there is any redness with that?
No redness.
Mm. Okay. Okay. And if we said that it's come and go, so if it come, it persist for how long? For hours, for days?
Yes, hours, doctor. Maximum hours. It's not exceeding.
Mhm. Mhm. Okay. And you feel at that time there is pain in both eyes.
Yes.
There is headache with it.
Yeah, doctor, I feel some dull aching in my head.
Mhm. And there is tearing in the eye or anything you
No,
notice?
doctor. No,
Mhm.
no, no tearing.
Okay. Okay. And anything you try to relieve this problem or become
Yeah,
better with anything? Mm.
I'm always taking rest and trying to sleep to overcome this issue. And
Mm.
sometimes it helps me.
Mhm. Okay. And anything worth it? Like seeing night movies,
No, it's not related.
like hot baths.
Yeah, doctor, you're right. I feel this thing happen always whenever I took some hot bath or in the weather, if the weather is hot, I
Mhm.
feel this comes with it.
Mhm. Okay. Okay. And do you have any medical condition in the past? Um, Like
No,
any condition diagnosed? Okay. Any admission to hospital? Any,
no,
okay. Any surgeries?
no.
Mm. Are you taking any medication?
Sometimes I'm taking painkillers for my this vision. I mean the pain in my eyes and the headache as well.
Mm-hmm. For how long you take it?
It's occasionally, doctor, whenever I had the headache or the pain.
Mhm. So not daily, not like daily.
No, not daily
Mm.
basis.
Okay. Any other medication you are on?
No.
Okay. Uh, uh, can you tell me if you have any weakness anywhere at any time to your body?
Yeah, sometimes, doctor, I feel weakness in my legs.
Mm.
Yeah, it
And
happens, doctor.
can you tell me when?
It's not no particular time, but it comes also like attacks,
Mm. Okay.
especially
And
with the hot bath.
any weakness, any low sensation or numbness?
Yes, sometimes I feel as well the numbness.
Mm. Okay. Any abnormal movement?
No,
Any like feeling not steady, unsteadiness?
yes, you're right, doctor. I'm always feeling dizzy and unsteady while walking.
Mm, I'm sorry for that. What do you do for a living or still study, Caesar?
No, I'm cashier, doctor.
Okay. And this condition, I think, affecting you.
Yeah, doctor, especially when I am counting or calculating, looking at this computer,
Mhm.
I feel double and it might harm my work, doctor.
Okay, I'm sorry for that, Mrs. And I'll try to help you by involving social worker also in
Mm-hmm.
our management. They can see how they can help. Are you drive, uh,
Yeah,
Caesar?
doctor, my own car.
Mhm. I'm sorry to tell you that you need to stop driving right now because it may be harmful for you and others. Till we will fix this condition and we'll tell you what we'll do next. Okay.
Okay, doctor.
Okay. Any high temperature?
No,
Any problem in your weight, like change in weight,
no,
increasing, decreasing? Okay. Any weather intolerance, like
no,
intolerating cold or okay. Any lump you notice in your body?
no,
Mhm. Do you have any joint pain,
no, doctor.
skin changes, rashes,
No,
any clot before,
no, doctor.
any bleeding anywhere?
No.
Okay. And do you smoke?
Yeah,
How many or how long?
5 cigarettes per day for the last 10 years.
Mhm. I really advise you to stop smoking, Lisa. It's very harmful for your health. And I can help you regarding that if you need.
Okay, doctor.
Do you drink alcohol?
Yeah, occasionally and at the weekend.
Hmm. Any binge drinking?
No,
Okay. Do you have bleeding anywhere, like any bleeding history?
no.
Do you have any family history of note, like any disease present in your family?
Yeah, my mother was having a migraine and my father had stroke
At what age the stroke?
at 60s.
Mhm. Any condition like you?
No, doctor.
Mhm. Okay. And uh, I'll ask you some private question if you
Hmm.
don't mind. What about your period? Any problem in?
No, it's okay, doctor.
Any chance to be pregnant?
I'm trying, doctor, but still no chance.
Any miscarriage before?
No,
Igor telefon.
Okay. Do you using contraceptive pills?
no.
Okay. Okay. Can I examine you, Lisa?
Yeah, sure, doctor.
Okay, I'll see general look of the patient if any dropping of the eyes in facial
Excellent. No,
feature. Mm,
You mean ptosis, right?
mm,
No ptosis.
Mitosis. Okay. I'll ask about the vital signs and then I'll check the eye
Yes,
acuity, both sides.
vitals is normal, blood pressure and blood pulse
Mhm.
and temperature.
Okay. Okay. The acuity.
You can start by the eye examination. Okay. Acuity is okay, normal in both eyes. She
Okay.
can
I'll
see the chart.
okay in both sides. I'll cover
Mhm.
each eye and checking for the visual fields.
Nothing intact, all fields she
Okay.
can
Then I'll
see.
check the H-shape movement for eyes.
Mhm. Yes, there is double vision
Mm,
in both
in
eyes,
on movement to
the
which
medial
side?
side. Yes.
Medial side. Okay. Okay. And if I cover one eye, this double vision will solve.
No, the same.
Okay. Okay, then I'll check the efferent pupillary reflex. I'll
Excellent. Yes.
making it
How?
like I'll let the patient put his hand between the eyes and I'll making swinging also
Mm-hmm.
to the light.
Yes. It's
Okay,
positive.
okay. I'll offer fundoscopy.
Okay, no need. But what you expect?
I'll expect maybe hazy disc if it is acute.
Okay, yes, yes.
Okay. Then I'll trying to check the neck, any stiffness.
No step.
Okay, I'll check overall the power, any weakness to raise the hand, checking for weakness, and
No weakness.
she can stand
Meanwhile,
from a chair without
she
help.
can stand without help. Yes.
Okay, okay.
What you
I'll
want to examine is, yes.
okay. Then I'll check the reflexes uh,
Mm-hmm.
in uh, the upper limb and in the knee. Any exaggerated or
Yes.
lost reflexes.
Yes. It's positive and exaggerated.
Mhm. Okay. And I'll uh, take a look to the neck. Is any swelling?
Nothing.
Okay. Then I can also checking the sensation in hand and feet.
Okay, good. So start by which one you want to start with?
I'll start if I ask her any lost sensation, any problem sensation, if
Okay,
she making
it
any
wasn't the feet or the legs. Okay, what you want to
okay.
examine now on the
I'll
feet?
check the soft touch comparing to the face and the needle,
Okay, what
the
do you
pin
think?
prick decreased in any side,
Intact. No,
intact.
intact.
Okay.
Okay.
And
What now?
I'll check the gate,
The gate. Intact, I said intact for the soft and
pin
pinprick.
pricking.
What
Okay.
else you want to examine? 2 minutes left.
Uh, uh, if 2 minutes, I'll let her walk
Okay, she has spastic gait
past the gate. Okay. Okay.
with some, yeah, with some unsteadiness.
Mhm. Okay. Okay. So what's your concern, Ms. Leila?
Yes. What I have, doctor, is it a stroke or mini stroke?
I really appreciate your concern and worries, Ms. Lisa. In your condition, most probably you have condition called multiple sclerosis. This is when your defense system attacking your nerves in your brain, and it can have the same manifestations that you have, like some weakness or uneasiness or problem in your vision. So it is most probably it's not stroke, but we will also consider this in our investigation, and we should exclude it.
Mm-hmm.
Okay, so I'll admit you right now to run some tests and to include the eye doctor in our urgent management, so we can see if there is anything we can do to you to avoid the hazard of this condition to you. and I'll update you when we making some scan to your brain, so we can know if you confirm the suspicion of this diagnosis. Do you have
Okay.
other question? Okay.
Is it curable, doctor?
I'm sorry to tell you, Ms. Lisa, that is can control this condition, but no cure for it. But with good management, we can avoid the hazard of this condition and not causing disablement forever to you.
Okay, time is up.
Okay.
Examine your question. Present your case and give me
O-
differential.
Okay. I see from this young lady that she has double vision on and off through the last year. She also experienced some weakness and some problem in sensation on and off. Uh, she has no history, like risk factor of clotting or bleeding. The examination that performed that confirming that there is some diplopia on some side and on one side, and there is also pain and positive afferent pupillary reflex. So and also spastic gait with some problem in some cerebellar sides like unsteadiness. So my first differential for this case to be systemic sclerosis according to the presentation and her age.
What you name it? Systemic sclerosis?
Yes,
Systemic sclerosis?
multiple. Sorry. I'm sorry.
Okay. What's
Multiple
your
sclerosis.
differential? Okay, what's your
Multiple
differential?
sclerosis. Okay. My differential, I'll put first TIA also.
Mm-hmm.
Maybe she has any coagulopathy, any hemophilia, any not hemophilia, thrombophilia. I'll put also in my mind uh, like strokes, previous strokes also. And also I'll put uh, uh, it is
Give me
less
differential for,
conversion disorder, but it is less possible.
okay, double vision differential.
Double vision, it is like temporal, not temporal. Okay, it is first optic neuritis. Even if not from multiple sclerosis, it can be alone. Okay, and like neuromyelitis optica, and it can be also from something from the eye itself, like glaucoma, and it can be also problem like stroke also or TIA.
Diplopia, double vision. What you give me all like differential for vision problem, but for the diplopia itself, you asked
Uh,
me, is it related or is it in the evening time? Why you ask for this question?
okay. The myasthenia and myotonia.
Okay,
Uh,
myasthenia gravis, and then okay, what
yes.
else?
And
Myasthenic
also
dystrophies.
the with thyroid disease, it can cause ophthalmoplegia. Uh,
Okay, how you investigate this patient?
okay, I'll start by running MRI to the brain and with basic investigation like
Mhm.
complete blood count and the inflammatory markers, liver function, kidney function, and may I also need to do some autoimmune profiles, and I may need lumbar puncture for this patient.
What you
All
expect in the lumbar puncture?
I'll expect I don't know really, it is like oligoclonal or
Mm-hmm.
uh,
Yes,
oligoclonal band.
yes.
Mm.
Okay. What else? Specific investigation for multiple sclerosis.
It is mainly symptomatic or manifestation diagnosis, but symptom diagnosis according to the symptom, but MRI with gadolinium, I think it is the target
Yeah,
investigation.
yeah,
Mm.
the investigation of choice. Okay.
Mm.
Evoke potential, you will do auditory
Yes,
and
visual
visual.
effect vision. Yes, yes, yes. I'll do visual effect potential and about the problem in also in gait and nerves. We can also do a some test like EMG and nerve conduction study.
Okay. Will you do some vitamin screening?
Yes, we can do vitamin B12 level.
Okay.
Um,
How to
uh,
manage this patient?
mm,
Time is up, but I add 1 more minute. How to
o-
manage?
okay, I'll admit this patient.
Mm-hmm.
Management will be include non-pharmacological and pharmacological. I'll educate the patient about the condition and trigger factors and how the management will be and the regular follow-up. I'll include in my management the multidisciplinary team, including the neurology and ophthalmology and the physiotherapy. Also, maybe the psychiatrist. There is several lines for management the multiple sclerosis. This is will discussed with the neurology doctor specifically, and this is a proper management line. But we can start by steroid to save the vision till the further management start.
Okay. What pharmacological therapy you know apart from steroid?
For multiple sclerosis,
Mm-hmm.
okay. I know about interferon alpha, this sphingoloid, and
Interferon beta.
glutamer acetate.
Mm.
Okay, this is
And what's called this medication or this
uh,
name, the name of this group?
all the
Dra-
groups.
Yeah, the MS, multiple sclerosis medication. What's called?
I don't know, but it's immunomodulatory like that. I don't know. Disease modifying? Or I
Yes,
don't know.
drug
Disease
disease
modifying.
modified agent for
Okay, for multiple
multiple sclerosis. Demands.
sclerosis.
DMANS.
Okay, disease
Okay,
modifying
disease
agent.
modified agent for multiple sclerosis. Okay, the last question. What the types you know for multiple sclerosis? The common type.
Okay, first will be the relapsing remitting, and
Mm-hmm.
maybe one on or one episode only, and there is progressive disease, and this is the worst, and there is progressive. What is this?
Primary
This
progressive, secondary progressive.
yes, primary progressive and secondary.
At least know the names only. No need to mention the details of this type. Okay. Primary progressive, secondary progressive, and relapsing remitting. This is the most common types. Okay, let's
Okay, yes, okay.
time's up. I will ask you question about your performance. What do you think about your performance?
I don't know.
Yeah,
I did my best.
you did your best, but you missed
Some, yeah,
a lot of
maybe.
things. You
Mm,
catch the case, right? I think
yes.
yes, you know. So what you missed in the history and as as well in the examination.
I missed the cardiac signs because it may be AF like showering,
It's
TIAs like
no, no,
that.
no, 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 no.
Ah,
It's not TIA or stroke at all. The stroke was distractor. I'm talking about MS signs and symptoms. This patient
signs.
clinically diagnosed multiple sclerosis. Start from the CNS. What you missed in CNS, the patient might have. I'm
CMS,
I'm
the speech
talking
and
as
speech
excellent.
and
Okay, speech. Okay,
uh,
swallowing. What
swallowing, speech
else?
and
What
swallowing.
else? The mood, right?
The mood, yes.
And
Yeah.
memory,
Memory.
right?
Okay. It is
And
affect the
depression.
memory of MS.
Yes, it might affect the memory, the mood, as depression, I mean, and the
Okay.
speech.
Mhm.
swallowing, hearing, and vision, as
Mm.
I said, and the balance. All CNS, you should analyze it well. Okay.
Okay.
I I give you this case because it's very common case in the exam, as long or short. Neuro, you might have it as lower limb examination or even cerebellar signs and symptoms.
Yes.
Uh,
Yes.
right? So let's recall the case together and the topic together.
Okay.
Start. We finish the CNS analysis. You have to expect a lot of things in the CNS. Apart from the CNS related to the MS outside the brain, I mean, what you could find.
Mhm.
Now we finish the brain as vision and hearing, weakness, numbness, imbalance, and mood, sleeplessness, feeling tired, all these things finished. What else in the body might be related and affected by multiple sclerosis? Other
Mm.
system.
Other CNS? I don't know.
CNS, but control some other system. No, urinary, right? The control of urine and tract
Yes.
passage.
Yes. Yes.
Yeah,
Yes.
if you ask me, I will tell you, yes, I lost the control one day, and this is also, or it might be retention with the need for self-fertilization. I know you know
Mm.
these things, but you should be targeting the
Yes.
questions. You have to ask
Yes.
all the things like you are searching for the MS signs and symptoms, showing the examiner that. Okay.
Yes.
Okay. The walking also you can ask either the examination or the history. I will tell you I feel difficulty in walking. Why? Because I had spasticity in my legs and I cannot walk well.
Mm.
Okay.
Yes.
So these are the MS in the history point of view. Apart from this, the social, the travel history and medical history, medication, surgery, allergy, then the HIV here is not important. The occupational, the job, the driving, very good. You touch these things, and the smoking, alcohol. Other system review, you just ask very quick questions for the chest, any chest pain, awareness of heartbeat, short of breath. It might
Mm.
happen also association with the multiple sclerosis because of
Yes.
maybe anemia or fatigue and constitutional symptoms you asked already. So what you missed in this case, the CNS analysis in details and the urinary system as control and also
Mm.
for the bowel control. Okay. And
Mm.
then let's go to the examination. What you miss in the eye examination? This is your
Mm.
complaint. So you started by acuity. Remember always afro. For any eye examination, afro, right? A
Mm.
for acuity, F for fields,
It,
R for
uh,
reflexes.
the corneal, yeah. I missed the
Ref-
corneal.
y-
I'll
not
offer.
only corneal, not only
Uh,
corneal, pupils. The pupils.
I
You
asked
didn't.
for it, yeah.
What you
I,
asked?
I, if I will do the afferent
Okay.
papillary, I'll check first the
No,
eye, the red reflex, yeah, or what?
no, no, no. This is
Uh,
different reflex. Marcus gun, pupil reaction is different than
oh,
the
the
H shape
accommodation?
and the
Oh,
accommodation also you missed, right?
mhm. Okay, yes.
And ophthalmoscope you offer already for optic neuritis.
Mhm.
But of course, they will not show you the pupils, or sorry, the ophthalmoscope because it's difficult. It might have pupillary reactions. Anyway, you have to offer endoscopy. So let's go back to the pathognomonic finding in the eye examination. You said afferent pupillary reflex, right?
Mhm.
And the accommodation will be also lost. How you do the accommodation reflex test?
I'll ask her to look to the wall,
Excellent.
then
Then,
look to the pen or the
yeah,
finger. Mm.
once, yeah, please look to the wall, then put the finger in front of her eye and ask her to look at your finger. She
Mm.
cannot do it, right?
Yes. Mm.
Okay, the Marcus Gun pupil, how you do it?
I'll let her put the hand between the eyes. Then
Mhm.
I'll like fluctuate the torch from side to side.
Excellent. You start by
Uh,
which side?
I think that this patient have the problem on right. I don't know exactly, but it will dilate on the affected side when you apply the torch.
Exactly. Yes.
Mm.
So you will check
But
by torch
rapidly,
both,
yes.
yes,
Mm.
both eyes. And the one you have meiosis in, you will start with. So you will apply the torch in the meiotic eye and
Okay,
immediately shift to the other eyes. The other eye will dilate,
dilate.
right? Supposed to constrict, but it will dilate.
Yes.
And for the accommodation, and we said what will be affected whenever you find these things. What's
The
called?
question, what is the affected?
Yeah,
The medial meniscus.
yeah.
Mm.
Medial,
Medial
longitudinal,
longitudinal
uh,
bundle. Yes, the medial
fasciculus.
longitudinal bundle. Yes,
MLF,
fasciculus.
malaf, yes,
Yes.
malaf. I'm calling it malaf, MLF. Okay,
What is the name? Sorry. Medial longitudinal or medial
whole
fasciculus or
medial longitudinal fasciculus, malaf,
uh,
MLF.
okay, okay,
Okay,
yes.
the accommodation we mentioned, the ptosis will not be there, and as you said, this will be for either myasthenia dystrophica or for myasthenia gravis.
Mm.
Okay, let's go back to the differential. What the differential here for double vision? You
What
said
you said?
multiple sclerosis. This is
Mm.
on the top, and this is the case. The second will
Mm.
be,
The double vision, we said that it will be the myopathies, it's like myasthenia or myotonia.
yes, myasthenia gravis and myotonia dystrophica.
Then the also thyroid disease or double
Okay,
vision.
what else
Mm.
in the double vision particularly?
Mm.
Sixth nerve palsy, right? Abducent
Yes,
nerve and cavernous sinus. Yes,
yes, cavernous sinus will
cavernous
affect.
sinus thrombosis. Yes.
Yes,
Okay, then the investigation, already you mentioned all of them, but what you expect in the MRI?
like the periventricular
Excellent.
demyelination. Yes,
And different N,
different
disseminated
sides. Yes, different
lesions,
sides.
yes,
Mm,
different site and density.
and and density. Yes,
Timing,
because
yes.
time.
What's
Yes,
the
time.
timing? Okay.
Yes. Mm.
And what's this criteria called?
McDonald, I think.
McDonald criteria, yes.
Yes.
Okay, this is for the MRI and this is the investigation of choice. The evoked
Mm.
potential, you said, for visual or auditory, and the CSF, lumbar puncture, oligoclonal bands.
Mm.
Don't forget always the baseline basic investigation. Why you might suspect anemia, vitamin deficiency, and the vitamin deficiency will be also here very important to correct if she has some vitamin
Prevent.
B12.
Yes. Mm.
Yes. Okay. The nerve conduction study or neurophysiological study, as you said. The management, as you said, starting always by multidisciplinary team approach, social worker, physiotherapist, for the spasticity, even neurology, sometimes they might need sterilization and
Mm.
other team. Of course, the neurologist on in the top. Okay. The pharmacological, as you said, the steroid in the acute relapse, high dose,
Mm.
and in between, the patient will be kept on demands drug disease modifying agent for
mm,
multiple sclerosis. Of example, as you said, fingolimod or interferon beta or uh, natalizumab, anything. The doctor will not go deep for the medication because the time will be at the end. Anyway, you have to know some of these medication. Okay,
yes, okay.
you have to read this topic again today because maybe it will come to you either in the
Yes,
short or
very
long.
important. Yeah.
And whenever you read it today, forget it. I mean, don't waste time again for it because you just practice it. But
Mm,
please remember the questions and the target question for multiple sclerosis in the history taking. Okay,
mm, mm,
I already mentioned to you.
mm. It's
Any
okay.
other point? Yes, of course. I missed the examination in the legs or the lower limb. You said the reflexes. You have to do all reflexes and including Babinski reflex. You didn't mention Babinski reflex. Believe me, the examiner are tough and they are searching for every single test in these cases. Babinski here is very important. What do you think in the Babinski?
It
That
can be equivocal or outgoing, but I
upgoing,
think
yes.
that's the time will be a problem if I
So
do neurology
don't do
at all.
examination. Yeah, do the important tests. So pronator drift important in the
Yeah.
hands and in the legs. Babinski reflexes. Do the reflexes in the legs. Okay,
Mm.
the Babinski and uh, knee reflex, ankle reflex, all will be exaggerated. The sensation, don't say, I will do soft and then break only. You have to do the deep sensation. It might be affected by the dorsal column, right?
Yes,
You
yes,
miss, you said only that, then you skip. No, it's important to do the deep. At least do one of the deep and one of the superficial. But don't do the deep, the superficial without doing the deep, because the deep is the one might be affected. Clear?
yes, 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 you're right.
Yeah, and the gate, as you said, the gate. If you have time, you can do the cerebellar, especially if the patient having hypotonia in both legs. So you will expect cerebellar affection. And whenever you do the gait, the patient is not ataxic, do the
Mm,
tandem gait. Patient might
mm.
be affected also because this is one of the criteria of the disease. The cerebellar might be affected in the
Yes.
multiple sclerosis.
Mhm.
The Danish, you know the Danish, right? You have to do the Danish. Of course, the nystagmus in the eyes and
Mm.
the the
The
Danish,
hypotonia and
hypotonia,
this
and this
the
diadochokinesia, but fast pointing,
uh,
yes, finger
yes,
nose
and
test, fast
slurred
pointing,
speech, yes,
spelled
and the
speech, yes, all of
nystagmus.
these. Yeah,
Yes,
I
yes,
remember also the nystagmus in the eye examination. You didn't do, right?
yes,
In the
I
H
did.
shape.
Yes,
Yeah,
yes.
it's very important. So what you expect when you do the
Uh,
H shape?
it will not the H shape, but nystagmus. The nystagmus.
Yes. Yeah, it
Nystagmus will
happened.
be more to the affected side.
So whenever
Gasping.
the
Mm.
eye the eye looking to the medial
Hesitant
side,
to yes. Hesitant to the
this
affected side. Yeah. Or
and
go
this is
get
also
to.
signs of
Mm.
yes, medial longitudinal fasciculus, right?
Yes, yes. Mm.
So don't forget all these things. It's very important in multiple sclerosis. If you have this case, you will be lucky because it's clear and the signs and symptoms are clear.
Yes, the problem will be the time to manage it good. Yes.
But once you catch the question by asking for the hot bath, and she'll tell you, yes, it's with the hot bath, this is your case.
Yes.
You have to be target in the question that this time. Of course, any vision problem, once you start, you have to ask also what you mean by vision problem. You spend 3 minutes and you don't know what is the vision problem. You ask a lot of questions. Be target from the first question. What you mean by vision problem? Because I might tell you a lot of symptoms without saying, because I spend also time waiting for the question, what you mean by vision problem? You didn't ask me. You asked me in
Mhm.
two eyes or one eye. What is it? What you mean by two eyes or one eye? What is it? What is the problem? You have to know what is the problem, right? The problem
Yes.
is double vision. So analyze the double vision, not the vision problem. Double vision. This is your complaint here. Don't go through the
Mhm.
vision and the color unless you know what is the main complaint, which is double vision.
Yes,
Okay?
yes.
Yes.
Mm.
Yeah,
So
the
the better
clonus.
to be the first question to
Yeah.
be the what you mean by the
Yes, exactly.
problem in
Yes.
vision. It is double, it is blurred,
Yes.
it is yes, okay. It is first
Yeah,
question. Better
exactly.
to be first question. Okay.
Because you will not feel the time. Whenever you are sitting there, you will not feel how many minutes passed, how many minutes remains,
Yes.
and you'll just take history. Suddenly, they might tell you 2 minutes left. Try to
Mm.
be fast as possible. Okay.
Yeah.
Dr.
Okay.
Samah Minch, thank you, Dr. Aisha. Any question? Any question, Dr. Aisha?
No, thank you. Thank you.
Okay, post your case in the chat box. I will read the comment. Dr. Samah commented,
Okay.
myasthenia gravis, myotonia dystrophica, cranial area palsy. Clonus is very important, yes. Whenever you have upper motor neuron lesion, you have to do the clonus. So whenever you want to start examination, neurological examination start by tone, power, reflex, coordination. Don't waste time doing these tests without organization. If you do in this organized way, you miss, as we did, me and you, Dr. Aisha, we miss what? We miss the coordination, the power, we miss the power because we didn't start in organized way. So we have to start tone, power, reflex, coordination, sensation. Try to start in organized way in order not to miss any of these. This is for any neurological case. Okay, any question from others?
دكتور باسم من الأنواع
Mhm.
برضه الأيزوليتد.
Yeah, it's yes, as you said, one of the types, but the commonest is common. The common is common. So what's the commonest type is? Yeah, the relapse limiting. If you didn't mention this type to the examiner, he will consider you didn't answer. Start by the commonest. And almost they are asking for three, not more than this, because always they are asking for another question. Whenever you mention one, two, three, he will skip to the other question because he has criteria for clinical judgment and the knowledge. He has some question. He has to ask you this question. Whenever you answer within seconds, he will skip to the next question. If you answer or not, he should examine and test you in all these things. So you can say yes, the fourth or fifth type, but the common is common. You're right for your answer, I mean. Okay, any other question or comment? Hello, anyone has comments? Okay, we have Miss Sarah, 35 years, complain of chest pain. Yes,
اه
anyone want to
خلاص
add
خلاص
comment?
عندي سؤال قلت لك الديفرنشال شنو الكيس ده
Yes,
صوتي ما مسموع
multiple sclerosis, myasthenia gravis, and myasthenia
مم.
dystrophica. Yeah,
مم.
also, you can put sixth nerve palsy or caverna sinus thrombosis. This is for the
عشان
complaint itself.
الديبلوبيا
Yes, for double vision. And you have to go
تمام
to analyze or to search for other cause of diplopia. As Dr. Aisha did, she has to ask about the evening time as timing for the complaint, rule out myasthenia gravis. The thyroid also you have to ask because this is a, co a common presentation of thyroid problem. Okay. Myotonia dystrophica, you roll it out by ptosis, any lid drop, eyelid drop. So it's And also the hand grip, myotonia grip. This will be for myotonia dystrophica. Okay, Dr. Aisha, we can start second scenario.
Okay.
It is chest pain. Okay. Just remind me 2 minutes.
I'll
Okay?
do the timing for you.
No, no. I put a timer. Remind me when 2 minutes remain.
Okay.
Tell me the 2 minutes left. Okay? Let's start. Dr. Aisha, are you there?
Yes, yes. Are you hearing me? My voice not clear?
Yeah, now clear. There was some interruption.
Okay.
Let's start.
Yes, we can start. Okay.
Hello there. I'm Dr. Mukhtar, the doctor in the clinic today. You must be Mrs. Sarah,
Yes, yes, I am doctor.
and you are 35 years.
Yes,
Okay, we are here to discuss about your health issue. Is that okay for you?
yes, doctor, please.
Yeah. I read that you have chest pain. Can you tell me more about it?
Yes, yesterday, doctor, I noticed this pain, and it is like very sharp. It hurt me a lot that I can't sleep at all the last night.
Okay, I'm so sorry about that, and be sure that we are here to support you and help you. Um, can I ask you, is it the first time in your life, or you have any previous attack?
I have some chest pain before, but it's not like that. This time
Um,
it is very bad.
and it started all of a sudden,
Yes,
and you feel it's worsening now, or the same as it started?
I think more worse.
And if I give you scale from 0, no pain, and 10 is the maximum, how can you scale this pain?
Sometimes it's reaching to 9, doctor. I think I
Do you
can
need some,
tolerate sometime, but it is very bad sometime.
do you need some painkiller now?
Thank you.
So again, you told me it was before. Is it the same in nature or different in nature?
The one attack before, it's 2 years ago, doctor. I can't remember good about it, but it's not very bad like that.
And any diagnosis for that?
No, I went to hospital. They suspect something serious, but they did some tests and said it's okay. And I go back home
You
with some
didn't take any
medication.
medication? Yeah, what
Yes,
medication you took?
just I can't remember good, but it's I think it's just some pain management like that.
Okay. Okay. What the nature of this pain right now?
Really, doctor, it's really sharp
Very sharp. In any site, particular site,
in some center of my chest.
center, does it go anywhere?
No,
Okay. And anything improve it?
I think I taking some painkiller and it helped slightly.
And do you think something can force it?
Yes, doctor. If I take deep breaths, I feel it is hurt more.
Okay. Any particular position to relieve this pain, or you feel anything in the position?
I can't lie down to the bed. It is increased the pain very bad, become very bad with it.
So whenever you sit, you feel better.
Yes, slightly.
Okay. Any recent infection, sore throat, or
No,
any infection anywhere in your body?
no,
Okay. You have any awareness of your heartbeat?
no,
Any short of breath?
no,
Okay. Any coughing?
no,
Any coughing up blood?
no,
Any noisy or noisy breathing?
No.
Okay. Apart from this, you have any pain, any area in your body?
Right now, doctor, no.
Okay. Did you feel sick at the same time of the
Um,
pain?
Not at the same time, doctor, but I'm really not good for the past few weeks.
Okay. What do you mean by you're not feeling good? Any high
I
body
feel hot.
temperature?
Yes, I feel
Yeah.
hot and shivery.
Okay. And any night sweat?
No,
Any lumps or bumps?
no.
How is your weight, Mrs. Sarah?
I think no change.
And your appetite?
Slightly not good.
Okay. I'm so sorry for that. Can you tell me if you have any past medical condition?
I have some condition in my finger, doctor, and I'm taking medication for years for it.
May I know what it's called?
I'm taking this drug Tifidibine because my fingers going blue when I should wear a thick gloves in winter.
Okay. And how is it now, this condition? Is it controlled?
Yes, with medication it is okay, and I am taking care to not to expose too much cold.
Great. You have any skin tightness?
No,
Any difficult swallowing?
no,
Any skin rash in your face or any areas in the sun exposed area?
no rash, doctor. But I think if I expose to sun, I feel like skin react badly.
In the face?
Yes,
Redness, you mean?
yes, like that. But just
Any,
not very bad.
okay. Any dryness in your eyes?
No,
Okay. And any joint pain?
yes, doctor. I have some problem in my joint of my hand. It is about 6 months ago, but it's okay now.
And you feel stiffness in your joint?
No, not too much.
Any change of the shape of your hand?
No.
Okay. Apart from this, any dryness, sorry for this question, any dryness in your private area?
No, doctor, I don't know.
Any muscle pain?
No, just I feel tired all the time and not good.
Okay. Any mood change?
Yes, doctor. I am depressed for the past 3 months. I starting some medication, and I am good now after the medication.
May I know what the medication was?
This fluoxetine.
Okay. And you are compliant to the medication?
Yes, I am better, but I think it is not like I hope.
Okay. You are taking any medication apart from fluoxetine? Can I see your medication list?
Just an amphetamine and the fluoxetine.
Okay. Any allergy to any medication?
No,
Okay, good. You have any hair fall or any problem in your hair?
no,
Okay. Any family history of same condition?
no, doctor,
Any travel history recently or before?
no.
Okay. Um, sorry, I can ask sensitive question, please. You have any problem in your period?
No, doctor.
Any miscarriage before?
Yes,
May I know when last time and how many times?
it is when I'm in 20s, doctor. I have 3 miscarriage, but I have now a healthy 4 years old boy.
Okay, so you have kids now.
Yeah,
Any chance to be pregnant now?
No,
Okay. Are you taking birth control pills?
no,
Okay, good. Uh, you have any headache?
no,
No?
no. Are
Okay.
you hearing? Okay.
Yes, yes. Any change of your bowel habit?
No,
Any change of your water work?
no.
Any frothiness in the urine?
I didn't notice it. No,
Okay. Any history of clot before?
no,
Stroke or mini stroke?
no.
Can I examine you? And while examining you, I can ask you some questions.
Okay, no problem.
So, how is the general look of the patient? Any change in the weight, or is she overweight?
No, it is
Nothing.
average. Yeah.
The vitals, please.
There is blood pressure slightly high, 160 over 95.
Okay. Do you smoke, Mrs. Sarah?
No,
Do you drink alcohol?
yes.
Socially and in the limit, within the limit?
Sometimes I drinking slightly more.
Any binge drink?
No,
Okay. And what's your job?
I'm a teacher.
And how the impact of this on your job?
It's really affecting me so much, doctor.
Okay, I'm so sorry for that. We can include our team to help you in this regards.
Okay, thank you.
Back to the examination, I will examine the hand, any deformity in the fingers,
There is some ulcers, small ulcers in one finger only.
calcinosis. Okay.
Yes, but other thing, no any deformity, no any.
Any sclerodactyly?
No,
Okay, any ulnar deviations, Z-shaped thumb,
no.
so no stiffness. I will examine the joint quickly. Any
Any?
effusion in the finger, in the joint of the finger, effusion or
You'll
hotness?
check for effusion, but first you'll ask about the pain and the
Yeah.
hotness and tenderness. Yeah.
Okay. Any pain in the hand, the
Yes,
finger?
there is pain, doctor. So just you will ask about basic movement. Okay. And the basic movement is okay?
Can you take this coin?
Yes, okay. It is
The
okay.
function, okay?
The function
Reverse
is
and
good.
yeah, prayer and reverse prayer you
Yes,
can
but
do.
with slight pain.
Okay. Now I will examine the tightness. I can ask her to pinch her skin up to the
No
elbow.
problem. Yes, no
Nothing.
problem. Mm.
Okay. Proximal myopathy.
Nothing?
Nothing. Any rash in all the chest or the back of the chest show sign, heliotrope in the face. Any rash
No,
or any
no,
skin
no
rash,
rush.
butterfly.
No, no rush at all.
Okay. Any dryness in the eye, any redness in the eye.
No, no,
Now I will examine the chest. Any
yes,
deformity.
no,
Nothing. And for the inspection, any change or any problem in the chest?
no,
Okay. I will examine the pulmonary hypertension signs,
nothing.
parasternal heave, and loud B2. Nothing.
2 minutes remaining. No,
Okay. I will auscultate the heart for S1, S2,
normal auscultation.
normal auscultation, no murmur.
No murmur.
Okay. And down to the leg, any edema.
No edema.
Okay, any joint in the leg, I mean any crevice in the joint,
No, no,
in the knee. May I
nothing.
know what's your concern?
What's the problem with me, doctor? Why I am fearing from this chest pain?
Yeah, I appreciate your concern, Mrs. Sarah. Uh, it's related to your previous condition, and I can say it's called pericarditis. Don't bother about the name. It's soreness around the areas around the heart. We have to run some blood tests and some image and scans to confirm the diagnosis and rule out other possible diagnoses. Is that okay for you?
Yes, doctor. Okay. So, this condition serious, doctor. I can cure from it.
I appreciate your concern. Yes, if not treated or if left not treated, it might harm your heart. For that, we have to admit you and we'll give you some medication to control this soreness around the heart. You have any other concern?
Okay, thank you, doctor.
Okay. Meanwhile, we can ask you to find another way for your control of birth apart from this medication. I mean birth control pills. Okay. And
Okay.
I will give you some instruction about controlling your condition.
Okay.
Okay. Any other concern?
Okay, thank you. Okay, time up.
Time is up. Yes.
Yes. Okay. I'll ask you what is your diagnosis and differential for this patient?
Yes. This lady, young lady, came with a complaint of chest pain. Severity is high, around 8 to 7, and it's worse with lying flat, improving with sitting up or in sitting position, I mean. Worse also with deep breath. So the differential or on the top of my differential, I can say this acute pericarditis due to sinusitis. On the background of her condition, she might have systemic lupus erythematosus associated with Raynaud phenomena.
Yeah.
Also,
Okay.
she might have an antiphospholipid antibodies syndrome.
Okay. So other differential for this patient, pain?
Yes, for the chest pain, I can think about acute coronary syndrome or PE, since she is positive or might be positive antiphospholipid antibody syndrome.
Any other things?
PE, acute coronary syndrome, and pericarditis, the case here. You
Okay.
want another differential?
Yes. Yes.
Ischemic, I think, yeah, muscle pain, atypical muscle pain,
Yes. Chondro.
neuropathy,
Yes.
and
Chondritis.
yeah,
This is also common with
chondritis.
systemic lupus.
Yes.
And GERD, esophageal pain. Okay.
Mhm.
Okay. So how you will investigate this patient?
Yes, apart from baseline basic investigation, CBC expected might have any type of anemia, hemolytic anemia, or microcytic anemia. Also, I can do inflammatory markers. CRP expected to be normal unless she has infection, ESR and procalcitonin, kidney function and liver function test and electrolyte, along with coagulation profile. This is in general. Specific investigation, I will do all autoimmune profile started by rheumatoid factor, anti-nuclear antibody, and anti-Smith, anti-double strain antibodies for Raynaud. Sorry, no antibodies for Raynaud. So antibodies for antiphospholipid syndrome,
Yes.
anti-cardiolipin, and beta-2 glycoprotein. And I can do some image in this patient, particularly thinking by echo or chest X-ray, and rule out other association like, yes, I could think to do HR CT chest if I suspect anything in the chest.
Okay. So you will admit this patient?
Yes, she might be in need for urgent admission. And if I suspect PE and this patient having a history of antiphospholipid antibodies, I can think about CT pulmonary angiography.
Okay, so how you will treat this patient?
Starting by multidisciplinary team approach, including the rheumatologist and immunologist, specialized nurse, clinical pharmacist, and social worker and physiotherapist. Then education counseling about the disease and the triggers, avoiding sun exposure and avoiding also cold exposure and other medical management, including pharmacological therapy
Mm.
for controlling systemic lupus itself, steroid in the relapse, high dose of steroid. Apart from this, I can think about steroid sparing agent. And if I suspect renal crisis, scleroderma renal crisis, as this patient is hypertensive, I can avoid steroid and think about AC inhibitors.
Okay, so how you will treat this patient pericarditis?
Yeah, pericarditis as sinusitis can give her some analgesic non-steroidal anti-inflammatory drugs, and I could think about colchicine, particularly in case of pericarditis.
Okay, if this patient has hypertension and you suspect she has some renal affection, what is other possible medication
Yeah,
apart from non-steroidal and colchicine?
ACE inhibitors.
No, for pericarditis.
For pericarditis with kidney affection,
Yes,
colchicine,
colchicine
no,
contraindicated.
colchicine contraindicated, so I can
Okay,
think non-steroidal.
aspirin. High dose aspirin is
Okay,
used in
aspirin,
treating
yes. Okay.
pericarditis.
High dose
Okay,
aspirin, yes.
okay. So I complete questions or stop?
Continue, no problem.
Continue. Okay. Okay. So this one of complication of systemic lupus pericardial, if pericarditis and there is renal affection maybe. What do you know about complication of pericarditis itself? What you will monitor this
Complication,
patient for? Yes.
yes, ECG and echo.
Yes. What's complication you can expect and monitor patients for?
Pericardial tamponade, the most
Okay.
urgent and the most dangerous.
How you will, if you will need to examine this patient to exclude that she has cardiac tamponade, what's the target examination you will do?
Cardiac examination and
What's the science? Yeah.
signs in the examination or
Yes.
the ECG or
Examination, science.
signs of pericarditis in examination or pericardial effusion. Yes, you
Oh, or
mean
tamponade, yes.
V waves, yes. Venous.
Tamponade, yes. Ejacular venous distension generally,
Yes, very
and
well distension,
signs of
yes.
edema or lower limb edema.
Lower limb edema,
Like,
yes.
yes. Restrictive
Right side heart
failure.
failure.
Yes.
Yes.
Okay. And for this patient, if she has effusion, okay, what you will do for her?
Pericardiocentrism.
Okay. Do you know other causes of pericarditis?
Yes, any sinusitis like familial Mediterranean fever, our case here, systemic lupus, or the Dressler syndrome, post-MI,
Yes.
and other autoimmune.
Yes, and also viral, and it's the most common viral
Yeah,
and
viral,
infection,
just
and
viral.
there is also bacterial infection. Okay. Okay, thank you, Dr. Bassam. Thank you very
Thank
much.
you.
Well done.
Thank you, Dr. Aisha, for a nice case. We
Okay, just
can
we will
hear
go
your
deep with
comments.
the case. Yes, I'll give you the comment first. Just you missed the GERD symptoms and the chest pain of
Yes.
MI symptoms. You should ask about if relieving by if it is more on exercise or no by name to exclude. And about the GERD symptoms also, you will okay. About saying if you have any infection recently, you should I think maybe some people said that infection is like jargon, so you can ask by name if you have bad bugs in your tummy or
Sore
in your
throat?
throat.
Okay.
Yes, in your
Mhm.
throat or tummy. And for other things about the if you'll examine for this patient, you should like yes, you will see the joint, but you should start by complaint, because if there's no time, you should finish the complaint, right?
Mhm.
The
Yes.
main complaint here is cardiac. So you just will start by hand to see the general symptoms, but then directly go to the heart. Because you will listen and you should exclude that she is in not failure and no GVP raised,
Mhm.
no edema, no murmur, no signs of failure.
Mhm.
Then you can proceed by the hand. The hand, if anyone said that she has joint pain, don't touch till ask about the pain, because
Mhm.
she may have pain, and if you moving her hand, you will see that ask the patient to making hand like that, making like that, ask about
Mhm.
pain. Then if no pain, you can check for effusion, and you should check for hotness by putting your dorsal of your hand on the joint, then on the normal skin, and checking for the hotness on the
Mhm.
all joint that she tell you that she has been in. Then ask for passive movement first, if she can move, because she will take a picture if she have any deformity, just stiffness or no, by the just the simple the active movement. Just you will ask for her to move, just to move, and you can put the hand when moving. Maybe you have some crack, crib or crackles, like
Yes. Yes.
crevitas, yes, crevitas.
Mhm.
Okay. So this is the examination of the hand, because it is present, maybe present if she has different episodes of joint pain, it can have
Mm.
some problem in restriction movement, and maybe some crackles also. Um, Examination will be for eye to see the pallor, because maybe associated with anemia, systemic lupus, and it can also you can also see the lower limb edema as you did. And the lung, I think, will be, if you have time, you will search for biphasial crepitation, or
Mhm.
the expansion
Yes.
here affected. It is really affected because she can't take deep breaths.
Mhm.
So you can comment on by just asking if taking deep breath, and you will check it's when you're doing the edema in lower limb. Just take deep breath and see how the expansion in to be
Mhm.
if reduced, you will say this is reduced expansion on both sides. You will ask if she has any pain when you're breathing her ribs, because before they bring like case of chondritis like that, and also it's the same complaint, the pain increasing with breathing deep, because also the pain of costochondritis, the same manifestation, it increasing with breathing deep, and it
Mhm.
is maybe in center or maybe anywhere. So you
Mhm.
will ask if you breathe here, you find any pain. So you will exclude this condition, because they can bring it faking patient or right patient. Yeah.
Mhm.
Okay. This is just all the comment, I think, from the history and examination. I think you catch all, and you ask about complication. And the differential here would be the acute pericarditis. Then you will see it like it's costochondritis or pleurisy or pulmonary embolism or acute MI. And against that, like that in each,
Okay.
yes, okay. Um, we can talk slightly on acute pericarditis, okay. The
Mhm.
acute pericarditis have there is like dangerous sign, or it is mainly as outpatient, okay, till
Mhm.
you find one of dangerous sign or red flag, you will admit the patient. But pericarditis simple condition, and can be managed as outpatient by simple analgesic like non-steroidal. if it is viral, if no any red flags. What's the red flags in any patient? To be has high temperature, to be have any trauma, to be on if you found effusion, if you find tamponade, if it's not responding to non-steroidal, like in severe pain, if you have other conditions suspected like this condition, this is not a simple condition, not pericarditis is simple, it is complicated by other case. So you will expect it not simply managed by non-steroidal. You may need the other disease modifying agent. Yes, even not steroid, maybe they will start by disease modifying agent directly in the hospital. Okay. So what is the management? Non-steroidal, colchicine and aspirin, all the three in the same line, يعني all effective as others. So you should choose according to the patient case. If this patient suspected renal affection, so maybe the aspirin will be the most suitable for health condition, and also you'll give protection like the NSAID, the gastric protection. Okay. So after that, how you will, if there is other causes of pericarditis, what is the causes of this? Can be viral, can be uremic, and what is the only solution for uremic pericarditis? To do dialysis, yes. And there is also pericarditis due to infection, bacterial also infection, and it can be related to the rheumatoid or any other neurological condition. And it can be post MI, and we said other consideration. Avoid, if it is viral, avoid steroid. If it is like related to systemic lupus, steroid will be first. It can be complicated by what? The most dangerous or problem is the effusion and the tamponade. Okay. And this patient need follow-up after pericarditis, because some patients have some problem in ejection fraction or the function of the heart after pericarditis. So they need after that follow-up. So what is called the uremic pericarditis is called the metabolic. It is because of renal failure. Okay. What other thing is?
What the dose of aspirin?
The dose 1,750 to 1,000.
Oh, high dose. Yes.
Yes, very high dose. Non-steroidal also high dose in pericarditis, 600 every 8 hours for 2 weeks. It is for long time with gastric protection. Okay, the colchicine, like any dose, half milligram daily or twice daily for 3 months. It is for long time. Colchicine working like cumulative effect. You should give for long time to have effect from it. I think this is all about pericarditis, and it's very common in exam because they can fake any patient have pericarditis because maybe no any symptoms. You will maybe no any signs. You will elect just he need to see you examining the target. That
yes, right. Okay, what is the ECG finding for pericarditis?
Yes, it is generalized SCT elevation. We'll find on all leads. Yes.
This is common, but what is the specific?
The BR will be
BR depression. So ST elevation could be there, but the specific one is BR depression.
Yes.
Yes, thank you, Dr. Aisha. Nice case.
So the complication will be recurrence and the tamponade. The recurrence rate is high for the patient to have first and the effusion and what is this? Pericarditis. Recurrence of pericarditis and the cardiac tamponade and effusion. Okay.
Myocarditis, right? Or not? It can be transmitted over the inner wall of the heart.
They said cardiac perforation, but I think it's not like
Not common like in MI.
not
Yes.
common to tell you.
Yes.
Mhm.
So what I miss here in
Oh,
the
in
differential
investigations, you
metabolic.
missed.
Yeah.
I think if you mention the investigation by this way, it will take time, and also the examiner will not be very reassured by. He may missed that the important point. So I think if we started by the specific, it is more
Better.
relevant,
Yes.
because if
Mhm.
this patient you will find, if you will not see the ECG and the cardiac enzymes
Excellent.
in the
Yes.
first
Yes.
and chest
Excellent. Yes.
X-ray, it will
Yes.
like missed in the
Yes. You're right.
dilemma of
This is what I
investigation,
missed.
because
Yes.
here we will investigate for systemic lupus, for antiphospholipid, for other complications. So you will a lot of investigation you said. But if you start by the most important, he will reassured,
ECG and
and
cardiac
maybe
enzymes.
he will
Yes.
not concentrate about the others, but just start by them. So he will know that you are safe doctor, and you will start by the target, that the one you are fear from
Yes.
it, like chest X-ray and ECG and D-dimer and cardiac enzymes. So you'll searching directory, then you will mention the other. I'll search for
Yes.
the cause. I'll confirm that it's systemic lupus, confirm antiphospholipid, because it can be need treatment for antiphospholipid, and I'll do basic also investigation for searching other problems, for searching kidney problem because she has hypertension. You should mention this all, but just start by the target. So he will like reassured that you are safe doctor, then he will listen for the other or not, as the question he has for you.
Yes. You're right.
Mm.
Supposed to start by ECG, cardiac enzyme, especially troponin and BMB,
Mm.
along with D-dimer to rule out the PE. This is the
Yes,
most important as dangerous cause of chest pain. Yes, you're right.
yes,
Then I
yes.
can do screening for autoimmune profile. You're right. Thank you, Dr. Aisha, for the case.
Mm.
Nice case.
Thank you
And
for the Dr. That's nice.
mm,
Also, the performance as usual,
thank you.
inshallah. Very good.
Thank you. Thank you so much.
Thank
But don't forget to read the multiple sclerosis topic today.
Yes,
Yes,
I'll.
please.
The most
Yes.
problem is that I said systemic.
Yeah, try it again and read it.
Yes.
It will be more
The
easy to
fingolomoid, a very important question
single
they
mode.
asking. If you start the
Yes.
fingolomoid, what you will do? You should admit, because there
Bradycardia.
is
Yes.
bradycardia effect, heavy block
Yes,
for
you're right.
some patients. So you should
And
start it.
natalizumab.
Yes.
Natalizumab. What's the precaution for natalizumab?
I don't know. This is the one I
The
remember.
complication. GZ
For
virus. GZ,
encephalopathy? Yes,
GZ
yes.
virus. Yes. GZ
Encephalopathy, yes.
virus.
Mm. Encephalopathy, yes. And also it's with, I think it was the others, it was interferon, I think.
Interferon. No, I think it's with the more with the natalizumab.
Maybe more,
Interferon.
yes.
I'm not
Interferon, we
sure.
should do the hepatitis and TB before starting. This is
Yeah.
question also a
Mm-hmm.
lot.
Okay. Thank you, Dr. Aisha, again, and thank you for
Thank you,
others for
Dr. Bassem.
listening. I don't know, today no more action and interaction, I mean, with the session. Yesterday it
Okay.
was, yeah, interactive too much with others. Dr. Azhar
Yes,
also today
I heard
absent.
this,
Yeah,
about
Dr. Azhar, one of
dilemma.
them. Yeah,
Yeah.
nice scenario also very prepared for the communication. You have to,
Yes,
all of us will have to listen. Thank
yes.
you again, Dr.
Thank
Aisha.
you.
Any question by you or
Thank
from
you.
others? Any question from others? Any comments? We finish early today. Okay, if no more question, we
Okay.
can end the session. Thank you, Dr. Aisha, again. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam.